medcram.com.
Hey guys, welcome to another MedCram video. We're going to talk today about amniotic fluid embolism. I was reminded about how quickly you need to react to this situation recently because I actually took care of a patient with amniotic fluid embolism and it was quite stark and it's something you'll never forget. So let's talk about it. Amniotic fluid embolism is a situation where you have a gravid uterus, which basically means you've got a uterus that is filled with fluid, but you've got a baby inside. Okay, I'm going to stylistically show this. And of course, amniotic fluid is all around. And you have the heart. You have the veins which come from the uterus and of course go up to the heart. The right side of the heart pumps blood to the lungs, which are here on either side, through the pulmonary artery, and then that spreads out into small pulmonary arteries. And of course, it gets oxygenated and comes back to the left side, where it gets pumped out through the aorta to the rest of the body. It goes to the uterine arteries and everywhere else. What happens with amniotic fluid embolism is somehow this amniotic fluid here gets pushed into the veins. And so what's in amniotic fluid is fetal hair, cells, tissue, all sorts of thrombogenic tissue and stuff that will basically cause mischief in the pulmonary artery circulation, not only by the fact that it occludes it physically by obstructing it, but also that when it gets lodged there, it releases cytokines, which causes all sorts of problems. And so it travels up the venous structures here, goes to the heart, and then gets pushed out and gets embolized into the lung. The right heart trying to pump, then it can cause all sorts of problems, which we'll talk about here. So this can happen in anywhere from 1 in 8,000 births to 1 in 80,000, depending on what literature you look at. And the mortality of this could be anywhere from 15 to 30% in some literature to as high as 70%. Some of the things that are very cardinal for amniotic fluid embolism is, number one, it can happen at any point before or after the first day or so, but it happens during delivery. Number two, there could be a seizure that happens at that time. Number three, there is cardiopulmonary collapse. And number four, the patient goes into something called DIC. Generally speaking, amniotic fluid embolism is going to happen in someone who is older, someone who's had births before, so multifarious, and also the risk goes up when there is induction. Why does it happen during delivery? Because during delivery, the pressure inside here, they believe, goes up and it kind of pushes this amniotic fluid into veins that may have ruptured during the opening of the birth canal. And this might be the reason why it pushes the amniotic fluid into the venous structures and up to the heart and then out to the lungs. Though it doesn't have to happen during that time, that is something that makes it more likely that that's what it is that you're dealing with. Seizures, because sometimes this stuff actually gets to the brain, can cause issues there as well. Sometimes it happens during cardiopulmonary collapse, which can happen. Cardiopulmonary collapse can happen because this stuff actually gets lodged and the heart may have a hard time pumping, and that can cause issues. Sometimes this cardiopulmonary collapse can happen later on because the amniotic fluid actually causes a cytokine release, which causes the clamping down of these pulmonary arteries, and that causes hypokinesis of the right ventricle on echocardiography. And then DIC, so these amniotic fluid products can cause something called diffuse intravascular coagulation. This is a situation where you have ramping up of coagulation factors, and so therefore the cardinal sign is you'll see a low fibrinogen level. Fibrinogen is the starting material for clots, and obviously if you're trying to make a lot of clots all at once, your starting material is going to go down. The other thing that you'll see is the INR go up considerably, and that's because you're not able to coagulate, so this is a thinning of the blood. You'll also see the platelets starting to go down as well. So DIC is characterized by this sort of a situation here. So the treatment of this is supportive care and to make sure that the patient gets what they need in terms of reversing the DIC, making sure they're getting good CPR and fluid resuscitation. They might even need vasopressors to treat their seizure, so that usually involves giving magnesium and giving them anti-seizure medications and making sure they're not still seizing. This needs to happen during the delivery. And of course, if you can get the baby delivered, that also is very helpful. It's important to understand these things before they happen, because when they are happening, things are happening so quickly you don't have time to look this stuff up. It's important to review these things, especially the review courses that we have here at medcram.com. So this was a lady who was a little bit older, and this was not her first pregnancy, and she was being induced. So already we can see here that there are some risk factors here. This was a normal vaginal delivery that was occurring. And during the delivery, the patient had a seizure during the delivery, and she basically went into cardiopulmonary arrest, and they started to code her with chest compressions. And by the time the critical care physician arrived, it was already 2 minutes in. They already had a pulse back, and the patient achieved ROSC, or ROSC, or return of spontaneous circulation. When they checked labs, they found that the patient had an elevated INR, had almost an undetectable fibrinogen. It was less than 60. And the platelets had not yet started to drop, but they were dropping, and so it was determined that the patient was in DIC. So basically, all of the hallmarks of amniotic fluid embolism was seen on this patient. One of the things that we didn't add to this, but came later, which is number 5, and it's really important as well, is right ventricular failure. Initially, the patient seemed to be actually doing well. The patient's blood pressure was in the 150s. Heart rate, of course, was very fast, 140s, because of this situation. But as the day went on, the patient's blood pressure started to drop. Initially, the patient's blood pressure started to drop because the patient was bleeding profusely. And that's what happens when you have DIC. Your INR goes up. And as it turns out, the patient was bleeding from the uterus about 6 liters of blood. And that's a huge amount of blood. That is actually the entire blood volume in most cases. But because this lady was pregnant, she actually had a much higher plasma volume than your normal human being. Still, though, this is almost nearly all of the blood that she was bleeding out, and it was coming out of her uterus. She actually had to go to the interventional radiology suite because she was too unstable for the operating room, and they actually embolized the uterine arteries in this case to prevent her from bleeding, and that significantly slowed that down. As it turns out, at the end of this, we had to give her 13 units of packed RBCs. We had to give her 4 units of fresh frozen plasma, 2 units of cryoprecipitate, which is important because cryo is very rich in fibrinogen. We also had to give her 1 adult pack of platelets, and that was just because of the amount of blood that we had to give her. And at that, she started to have some desaturation. She was on the ventilator and was having about 50% oxygen, PEEP of 8. By the way, for more information about how to ventilate these patients and how you need to do that, look at our ventilation series. Despite all of this, the patient started to become hypotensive. We had an arterial line in her, and the question came up was, with all of this volume that we're giving her, why is her blood pressure falling? We had initially done a quick look echocardiogram, and it looked like there was good movement of the myocardium. But later in the day, we got another echocardiogram, and guess what that showed? And you would be right if you guessed right ventricular failure. And what's going on here is that over a period of time, the amniotic fluid is starting to have an effect on the pulmonary vasculature, which is clamping down, and then it is therefore causing a lot of problems with the right heart, and it's not able to pump. So she was going into right ventricular failure. So at that point, we had to add dobutamine. And the reason why we tried dobutamine as opposed to Levophed was because we felt this was more cardiac. And if you look at our vasopressor protocol instruction on medcram.com, you'll see why we chose that. It's because it's got a lot of beta, and that's going to help out the heart, pump blood to the distal organs, and make sure that she's doing better. So after we started dobutamine, blood pressure actually started to come up, and she started to mentate better. We were actually able to bring up the fibrinogen levels pretty well. Here you can see fibrinogen levels. Initially, when we started off, it was around 60, which was well below the threshold of where it should be and indicative of DIC, with additional of cryoprecipitate, which was to replace the fibrinogen, and also starting a tranexamic acid drip, which was to slow down the fibrinolytic action of the DIC. You can see here that we had a very good response in bringing up the fibrinogen in elevation. And that was not only accomplished by giving a gram of a push of tranexamic acid, but also putting this patient on a drip of 1 gram over 8 hours. And that was around 12.5 cc's per hour. And you can see here that the INR quickly improved. Here was the hemoglobin, and you can see here it was kind of hovering all the time around the 9 to 10. And this is despite the fact that she lost 6 liters of blood. So how is it possible to lose 6 liters of blood, but also still have a regularly normal hemoglobin? And that has to do with what happens with re-equilibration. So if you were to lose that much blood, we're not replacing it with fluid, so that would cause the hemoglobin to drop. You're just checking the concentration of the blood left. And since it's happening so acutely, you're actually not even having time for the hemoglobin to drop. And we talk about that in our CBC lecture, so something to look forward to there. If we look at the vital signs here, you can see that the patient was having right ventricular hypokinesis, and with that, the blood pressure was low. The reason why the blood pressure was low is because there was an obstruction happening at the level of the pulmonary artery. The right ventricle was unable to pump blood through the pulmonary artery to the pulmonary vein and therefore get blood back to the left side of the heart. As a result of that, we had very low blood pressure and the heart rate was generally fast. What we decided to do was to add dobutamine, which is a pure beta. And as you can see here, that improved the blood pressure significantly, but it also increased the heart rate. Another thing that might be considered here is milrinone, which tends to reduce the pulmonary artery pressure and might be a reasonable choice. Levophed is also a reasonable option because it does actually have some beta activity in it, and it will cause the heart to contract. We decided in this case, because of the severe hypokinesis of the right ventricle, to use dobutamine, and that had some pretty good effects, even as you can see coming down here towards the end of the day with blood pressures at 137 and heart rates that are starting to come down, presumably because she's turning the corner here and actually doing a lot better. You can see here that she was saturating well on just 50% oxygen. Let's briefly go over what the pathophysiology is for an amniotic fluid embolism. There are three main pathways that occur that we need to be able to modulate or even block. And the first one is vagal reflex. We'll talk about these individually. The other one is the release of these inflammatory mediators. The third one is pulmonary vasoconstriction. So first of all, vagal reflex is going to eventually lead to a reduction in the vasomotor tone. And so if the patient's bleeding, they could become hypotensive. But in addition to all of this, vasomotor tone reduction can cause hypotension. And that is a problem that we see in amniotic fluid embolism. So the other thing that is going to happen with the inflammatory mediators now is there's going to be release primarily in something called serotonin. And serotonin is a very powerful substance that can stimulate platelet activation. And that in turn releases a substance called thromboxane, which leads to coagulation cascades and eventually leading to DIC, which is diffuse intravascular coagulation. This is what causes bleeding. The amniotic fluid embolism can also directly lead to the coagulation cascade as well. And thromboxane is an inflammatory mediator which can hype up this cycle. This is a definite problem. In addition to all of this, serotonin not only increases platelet activation, but it can also cause pulmonary vasoconstriction. And pulmonary vasoconstriction can lead to right heart failure, which again leads to left ventricular failure, because if there's no blood getting to the left side of the heart because the right side is failing, then the left side of the heart cannot pump. This is the situation that we're dealing with in amniotic fluid embolism. We have vagal reflux, we have inflammatory mediators, and pulmonary vascular constriction. And the vagal reflex is going to cause hypotension. The inflammatory mediators eventually lead to DIC, and pulmonary vasoconstriction is going to lead to eventually left ventricular failure and also, generally speaking, hypotension. What we want to do is we want to interrupt what is going on here. There is a protocol called the AOK protocol. I'll write it down here, AOK. And while this has not been validated with a randomized placebo-controlled trial, this is often discussed in the literature about what to do in these sort of situations. I'm discussing this not to say that I am recommending this or saying that this is actually well known in the standard of care, but it is something that has been looked at and is being researched. And it's something that should be considered on a case-by-case basis. So the AOK, A stands for atropine, O stands for ondansetron, and K stands for ketorolac. And we'll talk about why those three medications are thought to help out in this situation and stop the cascade. So we'll look at this now. Atropine is an antivagal. It's a vagolytic. And so if we want to break this chain of cascade, then we will give atropine. Atropine only lasts for so long, but it is thought that it would break down this pathway here and prevent the hypotension. So that's why atropine is given early on in some of these situations. The O, as we said, stands for ondansetron, and that is because ondansetron, which has some anti-serotonin properties, would interrupt at this point and also at this point. And by the way, ondansetron, otherwise known as Zofran, is a medication that's given here to see if they could prevent the pulmonary vasoconstriction and the platelet activation that can occur in this situation. So that's the O. The K is to prevent thromboxane from initiating the coagulation cascade, and it's also from causing more inflammatory factors. So this is ketorolac, which is a NSAID, and as such could actually make the bleeding worse if we are reducing the capability of the platelets. So we have to be careful in this situation. So in our case, in our patient that we talked about, she actually was given the AOK protocol. Let's talk about the other things that were given to her as well. We gave also dobutamine. Dobutamine, as you may know, is going to prevent right heart failure, and it's also going to prevent left heart failure in this situation so that the blood can be pumped effectively. We did not give Levophed, but you could. That is a vasopressor. For more information on vasopressors, check out our vasopressor protocol at medcram.com. But vasopressors can interrupt the cascade to prevent hypotension. In our situation, DIC had already kicked in, and two of the things that you can do to help out with DIC is replace the fibrinogen that is being used up, and that is by giving cryoprecipitate, which we did, as well as some other blood products. And the other thing that you can do to slow down the fibrinolysis is tranexamic acid, and that will also do it as well. Fortunately, all of these interventions were employed because the diagnosis was quickly obtained. And fortunately, our patient was extubated and doing well. The baby also managed to get some skin time with the mom, even though she was intubated. So everything seemed to have worked well. But of course, we don't have randomized placebo-controlled trials for this. It's not easy to do because you have to enroll patients like this in a trial that's already ongoing. And so because of the quick nature of how these things happen, it's difficult to do these kind of trials, these type of studies. So I bring this up again because it's something that you need to think about, especially if you're in the critical care world and you're called emergently to a delivery where the patient has gone into a cardiopulmonary collapse. Some other differential diagnosis that you need to think about is an air embolism. Treatment is reasonably about the same, although it's a completely different mechanism where you're actually getting air into the cardiovascular system. Again, you need to put the patient in the left lateral decubitus position. That means with their left side down to keep any air in the right atrium. You also need to put their hips above their heart to keep any air that might be getting in down below and not going up towards the heart. The other thing it could be is a pulmonary embolism. So if there was a blood clot in the leg and that traveled, it could be going into the lung. That could cause cardiopulmonary collapse. But you're not going to see things like DIC. You wouldn't necessarily see a seizure. You wouldn't see that happening ideally during delivery, although it could happen. So this patient actually had just about every single cardinal mark of a amniotic fluid embolism. Let's just go over those again. Number one, older. She's had deliveries before. She was being induced. It happened during delivery. She actually had a seizure during that period of time. There was cardiopulmonary collapse. She was in pretty significant DIC with an INR of greater than 3. Her fibrinogen levels were undetectable, INR was elevated, platelets were starting to go down, and she had right ventricular failure. So she had all of these things. Fortunately, with knowledge of how to treat these things, we were able to treat her effectively, and I'm happy to say that she was making great improvement, and her newborn child is going to get to know who mom is. A couple other things I wanted to mention to you. There is some research ongoing in terms of anti-complement treatments. There is nothing substantial yet to show that that actually helps definitively. There's also a question about steroids, antibiotics, things of that nature. But generally speaking, supportive care is the rule of the day. If you found this helpful, join us at medcram.com for more videos on medical education topics, including continuing medical education units. Hey, why do we do this? Because anybody can look at Google and try to figure out what's going on, but there's just some things that you need to know before they happen. And for that, there's medcram.com. Thanks for joining us.